Ruxolitinib is currently the only approved drug for MPN-associated myelofibrosis, and it's a great drug for spleen and symptoms in particular. However, it does have some limitations. It can cause anemia and thrombocytopenia, especially early on. It gets better later on, but initially it can be a challenge. And then the other limitation I would say is that it doesn't do very much to the bone marrow fibrosis. So that is an aspect of the disease that does not necessarily improve in most patients on ruxolitinib. Neither does it prevent transformation of myelofibrosis into acute myeloid leukemia. So those, in my view, would be the limitations. Sotatercept is a first-in-class activin receptor ligand trap. So that's the class of drugs it represents. And the way these drugs work is that they bind to a family of ligands, as we call it, that belong to the TGF-beta superfamily. So they bind to the TGF-beta superfamily of ligands, specifically something called growth and differentiation factor 11. And by binding to these ligands, it prevents their interaction with the activin receptor. And by doing so, it relieves the inhibition that these ligands cause of erythropoiesis. As I alluded to earlier, ruxolitinib, especially early on, causes anemia. In the first 12 to 24 weeks of therapy, it's probably the most pronounced. And then it slowly gets better, but it still leaves patients with a hemoglobin level that's lower than their baseline. And the reason it does this is that it's a JAK2 inhibitor. So if you block JAK2, you're going to cause anemia. So essentially the rationale is to combine ruxolitinib with something else that can counteract this anemia. It's really not a rationale based on any preclinical synergism in the laboratory or anything like that. However, as I explained earlier, Sotatercept improves anemia and has been shown to do so in preclinical models of myelofibrosis, and thereby the combination. The study I'm presenting here at an oral session tomorrow is, as you said, a phase 2 study of Sotatercept either alone or in combination with ruxolitinib in patients with MPN-associated myelofibrosis and anemia. So we had 2 cohorts. Right now, as I'm presenting it, there are 28 patients in the Sotatercept alone cohort and 17 in the cohort with ruxolitinib. And basically, these were patients who could be anemic with or without a need for blood transfusions. And we saw a response rate of 35% or 7 out of 20 evaluable in the Sotatercept alone cohort, and of 23% or 3 out of 13 evaluable in the combination cohort. That the response rate would be a little bit lower in the combination cohort makes sense because you have a drug ruxolitinib that's probably counteracting some of the anemia benefit of Sotatercept. And essentially those are the main findings. We did see improvement both in patients who were needing transfusions and in those who were not needing transfusions. So that's a fairly broad question, and there's a whole slew of emerging agents being developed. But I will say that some of the newer JAK2 inhibitors might be closer to approval than some of the other agents. So there is a considerable excitement, for example, about fedratinib potentially in a second-line setting after ruxolitinib. There is another JAK2 inhibitor called pacritinib that may work in patients who have very low platelets, who are technically not candidates for ruxolitinib. There is yet another one called momelotinib that may be able to improve anemia a little bit in similar fashion to what Sotatercept might do, which is by acting through the activin receptor and blocking it. There is also a drug being presented here at EHA at the oral session called CPI-0610. This is a bromodomain inhibitor that has been studied both after failure of ruxolitinib and as an add-on to ruxolitinib in patients who are not having a sufficient response. And this drug has been promising as well. There are many others, but those are some that come to mind right away.